So good morning and welcome to today's webinar on Do You Have a Good Pair of Lungs? Practical Pointers for Respiratory Health, presented in collaboration with Friends Health Connection. Our lungs play an important role in our body, helping to get the oxygen our cells need to live. During today's webinar, we will learn more about how to keep our lungs healthy and the various types of health issues that can occur or can affect rather our respiratory system, from flu and COVID-19 to COPD and lung cancer. We are pleased to be joined today by Dr. Lee Gerson, a thoracic surgeon with the Steeplechase Cancer Center at Robert Wood Johnson University Hospital, Somerset, and Rutgers-Robert Wood Johnson Medical School, and Dr. Alpeshkumar Bavishi, a pulmonologist at Robert Wood Johnson University Hospital, Somerset. We will begin today's webinar with a moderated discussion followed by questions from our audience. First, I'd like to ask each of you to share a little bit about yourselves. So Dr. Gerson, would you be so kind as to start us off?
Sure. As Serena said, I'm a thoracic surgeon, which still falls under the umbrella of cardiothoracic surgery, which means my training and background is not only in surgery of the lungs, but basically the entire cardiovascular system. Thoracic surgery primarily focuses on, or the biggest portion of it, as it involves treatment of lung cancer, but it also involves esophageal cancer, diseases of the diaphragm and the chest wall and the mediastinum. I got into this because recently, with the adoption of lung cancer screening guidelines, lung cancer is becoming more and more of a at least a surgically treatable disease when caught early enough. So it's an incredibly important field and topic for public health.
Well, great. And thank you again for joining us. Dr. Bavishi, could you share a little bit about yourself with the audience?
Yes, hi, I'm Alpeshkumar Bavishi. I'm a pulmonologist currently at Respiratory in Bridgewater, and I'm affiliated with Robert Wood Johnson University Hospital at Somerset. I did my medical training at Mount Sinai School of Medicine, Elmhurst in New York, and I finished my fellowship in pulmonary and critical care from UMD-NJ, which is called Rutgers now, in Newark in 2004. And since then, I'm a practicing pulmonary critical care physician. Happy to join you guys here today.
Well, again, thank you for joining us, and both. We truly appreciate it. We know how busy you are. So why don't we start off by discussing the lungs? So maybe Dr. Bavishi, if you can kick us off with how do our lungs work and why are they so important?
Sure. So the lungs are a pair of organs in our chest, and they are an important part of our respiratory system. Respiratory system does include other organs such as our nose, sinuses, mouth, throat, voice box, windpipe, airways, chest wall, rib cage. But lungs are the most important organs in our body. They primarily, when we inhale, the air goes inside our lungs, and from air, the oxygen gets extracted in the lungs and then transported to the blood, and then it flows all over our body. And similarly, the carbon dioxide, which is a waste product of metabolism, being transported from the blood vessels to the lungs, and from there it is exhaled outside. So the primary function of the lung is the gas exchange, which is essential for life. And other than that, the respiratory system also plays an important part in some other functions like talking. Larynx, which is a voice box, is an important organ which helps us to talk. Similarly, nose helps to smell. So these are some of the other functions of the respiratory system. but the primary function is the gas exchange, ability to extract oxygen inside of our body, and ability to exhale carbon dioxide, a waste product.
Great, thank you so much. So what are some of the other parts of the respiratory system?
As I just mentioned, so nose, sinuses, mouth, throat, which is pharynx, voice box, which is called larynx, windpipe. Then it goes to larger airways called bronchi, and then smaller airways called bronchioles. And then some other parts like diaphragm and muscles of respiration are also part of the respiratory system. Similarly, rib cage is also part of the respiratory system.
Great, thank you for that explanation, appreciate it. So what, do either of you suggest, what are some general tips you can give the audience for keeping lungs healthy?
Well, it's a good question, absolutely. So to keep lungs healthy, the main important things I would say, suggest or recommend is don't smoke. Smoking is the biggest problem, causes multiple diseases, including bronchitis, emphysema, COPD, and cancers, including lung cancer. So to keep your lungs healthy, don't smoke. Other thing is avoid pollutants that can damage your lungs, like second-hand cigarette smokes, like chemicals and a gas called radon, which is sometimes comes through underneath the land, and in your basement, people do test their home for radon. That's also a known carcinogen, can cause lung cancer. So avoid these pollutants. Avoid exercising outdoors when the air quality is bad. Wear a mask when you are working in an environment when you're going to be exposed to the dust, fumes, and other pollutants that can damage your lung. Wear a mask. Be physically active. Being physically active can strengthen your heart and lung, and physical activity reduces your risk of many diseases, including lung diseases. Also important to prevent infection by washing your hands often, getting your vaccination on time, such as flu vaccine, pneumonia vaccine, and nowadays COVID-19 vaccine. If you are sick, stay home, well hydrated, get better, and keep a distance with the other members of your family to prevent infections to them. And as I mentioned, exercise is also an important part of our lung health. Moderate exercise every day helps to keep your lung healthy. So these are the general tips I would say, to help your lungs in a good condition.
So, and with winter coming up, some of these may apply, but how can we prevent respiratory infections during cold and flu season, and of course, the pandemic? I think you mentioned some of them, but if you could maybe speak to that.
Yes. So to prevent respiratory infections, you should avoid close contact with the people when you are sick. Keep distance, especially when you are going through initial phases of respiratory illness. You stay home. Hydrate yourself. Don't go to school or to the work till you are better. That will prevent spreading this infection to others. Cover your nose and mouth with a tissue when you're coughing or sneezing. This prevents getting the infection out of your nose and mouth to the others. Flu virus is mainly spread by droplets. So it's important, if you have a flu, cover your mouth and nose when you are coughing or sneezing. Keeping your hands clean and nice is important. So washing your hands often will prevent, will protect you from the germs. Use soap and water. If it's not available, use alcohol-based hand drops. Avoid touching your eyes, nose, and mouths. Also, taking flu vaccine yearly. Ask your doctor for pneumonia shots if you qualify. And as I mentioned earlier, COVID-19 is a respiratory illness, which also can be spread by droplet infection in airborne way. So keep yourself in a good condition, exercise regularly. These are some of the common things that will help to prevent respiratory infection.
Okay. So, when you talk about flu and COVID, they share similar symptoms. So can you explain or share with our audience how you can tell the difference between flu and COVID-19?
Good question. Based on the symptomatology, it is very difficult to tell if there is a difference between flu symptoms or COVID symptoms. Both are respiratory diseases. One, COVID-19 spread by SARS-CoV-2 virus, other one is influenza spread by flu viruses. They share symptoms like fever, chills, cough, shortness of breath, difficulty in breathing, fatigue, sore throat, runny nose, muscle pain, headache, vomiting, diarrhea. You can't differentiate between two just based on the symptoms. But there are some differences in different ways. I would go through some of this with you guys. Compared to flu, COVID-19 seems to spread more easily. Also, COVID-19 is more contagious than flu, and it has more super spreading events than flu. It can cause more serious illness in some people, and it can take longer before people show symptoms with COVID-19 compared to flu. So people with COVID-19 may not show symptoms or show symptoms 5 days after being infected. In general, symptoms can appear 2 to 14 days after infection. With flu, symptoms generally appear 1 to 4 days after infection. People with COVID-19 can be contagious for a longer period of time. And as I said, COVID-19 can cause serious illness, including respiratory failure in some people and in some healthy people, I would say. So these are some of the differences in terms of how COVID-19 spread, how contagious it is, what kind of complications it causes. And that's the way to differentiate. Obviously, when you go to doctor and they test you, and then if your test is positive for COVID-19, you have COVID-19. When they test you for flu, if you're positive for flu, you have flu. It's difficult to differentiate just based on the symptoms. So if you're having some symptoms which you can't differentiate between two, it's better to go to doctor and get checked out.
I could just add, I think seeking medical attention is probably one of the most important strategies you can employ for all of these things, for preventing and treating these respiratory illnesses and for keeping a healthy pair of lungs, because a lot of, we see a lot of patients, certainly in the hospital, that have been complaining of symptoms of one kind or another for months and months and months, and they never make it to medical attention until it gets so bad that they have to be admitted. And I could just give you a very easy example that is very often overlooked. People with really bad heartburn and reflux can also have effects in their lungs and not realize it. It's one of the, it's on the potential causes, a list of potential causes for atypical asthma, for example. So it's very important that you seek medical advice when there's something going on. Don't try to be a hero, and certainly if you're sick, stay home. One very important difference between the flu and COVID-19 is when you have the flu, you get over the flu. People that have COVID-19, even mild cases, can have strange symptoms for a prolonged period of time. And then, but beyond that, up front, there's really no way to know unless you're one of those people that has something like loss of taste or smell. That is pretty unique to SARS-CoV-19 as opposed to the flu.
So thank you for bringing up a good point, Dr. Gerson. So COVID does have, as you've both discussed, an impact on lungs. So Can you explain for our audience, how does COVID-19 affect the lungs, and what long-term effects or impact, like PACs, does it have on the lungs? So
I think Dr. Bavishi.
yeah, Dr. Bavishi, why don't you kick
explain
us
that from
off,
a
and
pulmonary
Dr.
function test
Gerson,
standpoint.
yeah, you want to add, go to.
Okay, sure. Yeah. So COVID-19 causes multiple problems, primarily related to respiratory system. And important of them is pneumonia. It causes bad pneumonia. We have seen patients developing pneumonia on both sides, right and left, both lungs. And when the pneumonia is bad, it hampers your gas exchange, your oxygen transfer that we talked about. That oxygen can't get into your body, and your body can't exhale the carbon dioxide because your lungs are diseased with pneumonia. So it causes respiratory failure in that severe cases where people have low oxygen level in their body because of pneumonia. And pneumonia is so severe that they can't get enough oxygen. So pneumonia is one of the complications COVID causes. Acute respiratory failure with low oxygen level called hypoxia. And in severe cases, it can cause something called ARDS, which is an acute respiratory distress syndrome. When patients with respiratory failure worsens, their oxygen level worsens, they can't breathe, they may require a support from a ventilator, either invasive or non-invasive. And in that situation, we call a disease called ARDS, can happen in some patients who are getting sick from COVID. Sepsis is another thing that COVID-19 causes. And COVID-19 also affects many other organs, including your kidneys, including your heart. And it has now shown to be associated with clots in lungs, in legs, in heart. Secondary bacterial and fungal infection after you get viral infection like COVID is also a possibility. Talking about some of the long-term effect, so we are still learning a lot about COVID-19. It's a relatively new disease, but people who have recovered from COVID-19 initial illness may show some symptoms even if they were asymptomatic to begin with, or some of them who were symptomatic and got better. And some of the symptoms are shortness of breath, chronic cough, chest pain, palpitations, fatigue, difficulty in concentrating or thinking, now known as brain fog, headaches, dizziness, mood changes, changes in the smell or taste can last longer. Diarrhea, stomach pain, skin rash. So there are a lot of changes that can happen even after COVID is gone, which is now known as long COVID. And there are research going on about how to manage these symptoms at big centers in the United States.
It's important to highlight something that Dr. Bavishi just said, that you can have some of these long COVID type symptoms, even if you were asymptomatic or had a mild case of the acute COVID illness. So, you know, a lot of people think, well, you know, there's very little chance that even if I catch the virus, that I'm going to get really sick. That may be true, but you don't know what's going to happen down the road. So, you know, it's another plug for getting vaccinated and for wearing masks and for doing all the things that the public health experts have been recommending.
So if people can be asymptomatic, right, then how do they know that I guess those lung issues, maybe they'll think it's attributed to age. So does lung function decline as we age? Dr. Bavishi?
Yeah, I'll take the question. Yes, lung function does decline with age. Lung matures, I would say about 20 or 25 years of age. So after about 35, its function declines gradually, and there are several changes that happen in the body with aging that leads to decline in the lung capacity. Like muscles and other tissues that support your airways become loose, and their ability to keep the airways completely open diminishes. It results in air trapping. Like the air sacs called alveoli can lose their shape and become boggy, and people develop something called senile emphysema. The diaphragm, which is the main muscle of respiration, becomes weaker, and as a result, people may have difficulty in inhaling and exhaling. Rib cage, bones become thinner, change shape, and as a result, it cannot expand and contract as effectively when you breathe. So this structural changes impairs the respiratory system compliance, and it leads to increase in work of breathing. Also, the nerves in the airways that triggers cough when you inhale a foreign body, they become less sensitive as you get older. So respiratory muscle strength decreases because of all these changes, and people also get sicker more when they are older because their immunity is not that strong. So all this affects your lung function with age, and it declines, as I said, mainly after you reach 35 gradually.
Well, I guess something to look forward to, but like, can exercise counter that? I mean, if so, what exercises are good for lung health?
Yes. Exercise, especially 30 minutes of moderate physical activity, 5 days a week are recommended. And moderate activity includes like walking brisk, recreational biking, gardening, vigorous house cleaning. Both aerobic and muscle strengthening exercise can benefit. If you are biking or swimming or jump rope, they can help your heart and lung and improve its efficiency. Muscle strengthening exercise like weightlifting, it your core strength, improve your posture, and toning your breathing muscles. Breathing exercise in particular can strengthen the muscles of respiration, like your diaphragm, and it helps you to breathe more deeply and effectively. So a couple of exercises like pursed lip breathing, diaphragmatic breathing are some breathing exercise that people can do. And as your physical fitness improves, your body becomes more efficient at getting oxygen into the bloodstream and transporting it to the working muscles. So exercise are important part of lung health.
One point that's a natural conclusion to what Dr. Bavishi just mentioned is watching your weight. People that are obese have are at higher risk for respiratory diseases, respiratory insufficiency. So it's another way that being active and exercising to the extent that it helps maintain a healthy weight can help keep your lungs healthy over time. And all the things that Dr. Bavishi mentioned about aging are things we can't really do anything about. And when you add to that damaging your lungs from things like smoking, you start to realize why people, when they're former smokers or even current smokers, when they get older and they have all these other age-related changes, why they might need oxygen, and somebody who never smoked, even though they still have these age-related changes, they wouldn't need oxygen because we have some redundancy built in to the system. But if you don't treat those two lungs that you were given well for your whole life, you can run into some problems later on in life.
Yeah, so definitely sounds like exercise bad, or excuse me, exercise good, smoking bad, right? So just wanted to go back to a point or a point of clarification with Dr. Bavishi. When you talk about exercise, any misnomers between aerobic or anaerobic exercise? Like, what is the most effective way to improve your lung health?
So as I mentioned, it's a moderate physical activity. You can do aerobic activities like walking, running, jump rope, biking, swimming, or you can do the muscle strengthening activities like weightlifting that builds your core strength. You don't have to go crazy and do it, a lot, but it's just 30 minutes of moderate activity, which is what is recommended in general to improve overall health and also helps with your lung health.
And thank you for clarifying, because we hear also many times in the community that they feel like they have to have anaerobic, where they really have to work the lungs hard to really have those improvements. And I really wanted to kind of stress that point, that it doesn't have to be. So
Absolutely.
thank you for clarifying that. So let's talk about some of the most common health issues and diseases that affect our lungs. So first, let's look at COPD. Can you explain what it is, who's at risk, how you diagnose it, and what are some of those treatment options?
Sure. COPD, which stands for chronic obstructive pulmonary disease, is a common problem. It's a preventable and treatable disease that is characterized by persistent respiratory symptoms and airflow limitations, primarily due to airway and some alveolar abnormalities in the lungs, secondary to significant exposure to noxious particles and gases. Smoking is the most important risk factor for COPD, and symptoms that people can experience with COPD are shortness of breath, cough, mucus production, wheezing, chest tightness, and as I mentioned, there are primarily two subcategories under COPD that affects our lungs. One is called chronic bronchitis, when people have chronic cough with sputum production. The other one is called emphysema, where there is damage to your lungs. And it's a fourth leading cause of death in the United States. About 16 million people are diagnosed with COPD, and it's a progressive disease. Symptoms often worsen over time and can limit your ability to do routine activities. Going over the causes, as I mentioned, cigarette smoking is the most important risk factor for development of COPD. Other than that, secondhand smoke exposure, pipe or cigar smoking, other types of tobacco smokes, air pollution, exposure to the chemicals and dust from working in an environment at workplace. Sometimes I would say genetic condition called alpha-1 antitrypsin deficiency can cause COP in younger population. Also, people who have asthma, they can develop COPD. So these are some of the causes and the risk factor that puts people at high risk for COPD. In terms of diagnosis, you diagnose this disease with some testing. People who come with shortness of breath, cough, chest tightness, progressive limitation to activities, go to doctor. The doctor does something called pulmonary function test, which is to identify how much is the airflow limitation when they inhale and exhale. And based on that test, when there is no other explanation for patient's symptoms with history of smoking or exposure to other chemicals, doctors generally diagnose patients with COPD. Sometimes they order radiological testing like chest X-ray or CAT scan, but very rarely it is required for diagnosis of COPD. Treatment options, do you want me to go over now?
Sure, by all means, yes.
Yes, okay. Generally, treatment of COPD includes relieving your symptoms, slowing the progression of the disease, improving your exercise tolerance, and preventing and treating complications of COPD. And it starts with quit smoking. Very important because if you continue to smoke, your disease will continue to worsen. Even if you quit, the disease continues to worsen, but at slower pace. So it's important to quit smoking. That's the most important thing. I would start in terms of treating the COPD. Medications are an important part of COPD management. They are called bronchodilators, and it relaxes the muscles around your airways, and it helps to keep the airways open and makes the breathing easier. There are various kinds of medications available for COPD treatment. Generally, they are delivered by a device called inhaler, and there are different kinds of inhalers available in the market. The medications can be shorter acting or longer acting bronchodilators. And if your COPD is mild, doctor may prescribe you a shorter acting inhaler to be used round the clock or as required. But if your disease gets moderate or severe, the doctor may need to prescribe you combination of shorter and longer acting bronchodilators. As the disease advances, people may have problem with oxygenation and their oxygen level drops. So oxygen therapy is also an important part of COPD management in patients with advanced COPD. And there are certain criteria that doctors uses to prescribe oxygen. If your oxygen level drops below 88% in general, with at rest or with activities, doctor may prescribe you oxygen therapy. That may help to live longer. It has a mortality benefit. So oxygen therapy is an important part of COPD management. And similarly, pulmonary rehabilitation is also recommended for COPD patients who qualifies for it. It helps to improve general well-being of the people. It's a program where there is an exercise program, also disease management training, nutritional and psychological counseling. So a lot of things work together to make you feel better. And the program's goal is to help you stay active and carry out your day-to-day activities. And a lot of team members are involved when a patient is recommended to go to pulmonary rehab, like doctors, nurses, physical therapists, respiratory therapists, some exercise specialists, and dietitians. So these are some general treatment options. In advanced stages, also surgery might be an option, or a lung transplant might be an option for COPD management.
Okay. Thank you so very much. Now, of all the conditions I've heard you discuss today, I haven't heard yet, I don't believe, asthma. So that's another lung condition that we often hear about. So can you tell us what asthma is and who's affected by it, and how is it treated?
Yes. So asthma is another chronic respiratory condition that affects airways in the lungs. And if you have asthma, the airways can become inflamed and narrowed at times. And the classical symptoms of asthma are dyspnea, shortness of breath, chest tightness, coughing, wheezing, and it is brought on by characteristic triggers, and it is relieved by medication called bronchodilators. It affects people of all ages, children to adult, and definitive diagnosis of asthma requires presence of respiratory symptoms, along with demonstration of variable expiratory flow limitation on testing. Triggers that can set off asthma or worsen your asthma symptoms are cold air, exercise, exposure to dust, chemicals, fumes. When your asthma gets worse, people have to go to hospital or to the doctor. It's called asthma attacks, and doctors prescribe you medication to make you feel better. Exact cause of asthma is not known, but asthma is often the result of the strong response of our immune system to substances in the lungs. Normally, the body's immune system helps to fight infections. Sometimes a person's immune system responds to a substance in the environment called an allergen. When someone breathes an allergen, such as ragweed, the immune system in the airway may react strongly. In other people, they don't react at all. So the immune system reacts to the allergen by creating inflammation. And then that inflammation makes your airways swell and narrow and possibly produce more mucus. As a result, people have difficulty in breathing. So that's how asthma symptoms are brought in by triggers. Some risk factor: exposure to cigarette smoke when you are in womb or in early childhood years, exposure to different microbes like bacteria, viruses in the environment early on, exposure that happens at workplace, like exposure to chemicals, industrial dust, can cause asthma. Poor air quality, air pollution, and allergens such as pollens, dust, can cause asthma. Some people who have family history and genes, they may be implicated in asthma diagnosis. Allergies: if you have more allergies, you are more prone to develop asthma. Obesity has been also associated with asthma. So these are some of the risk factors associated with asthma. The way to treat asthma is, again, bronchodilator medications. The goal here is to manage your asthma symptoms and prevent asthma attacks. Most people are treated with long-term daily controller medications, and some also requires short-term relief medications. I would not go into too much detail. If you want, I can. But as I mentioned, these are the inhalers that generally doctor prescribes. In severe cases, doctors might have to prescribe a medication called prednisone or corticosteroids. Many other medications like biological therapies, immunotherapies, mast cell stabilizers. These are some of the other medications that doctors may use to treat your asthma based on the severity of your asthma.
Thank you very much. It was a very in-depth explanation of asthma. I appreciate that. So I want to also touch base on lung cancer. As we know, lung cancer is one of the deadliest types of cancers. So could you share how prevalent is it, who's at risk, and what screening options are available, and who is eligible? So I know, do you want to maybe talk about lung cancer, and then we'll kick it over to Dr. Gerson?
Okay. So lung cancer is the second most common cancer in the United States, not counting skin cancer. So it is a big, when you talk about cancers in general. And it's a leading cause of cancer death in both men and women, making up about 25% of all cancer deaths in the United States. Each year, more people die of lung cancer than of colon, breast, and prostate cancers combined. American Cancer Society estimates that about 235,000 new cases of lung cancer this year, and about 130,000 deaths from lung cancer this year. Smoking is the most important risk factor for the lung cancer. And tobacco smoke accounts for about 80 to 90% of cases of lung cancer. So stopping smoking is the most important thing you can do to prevent lung cancer. Smokers have about 10 to 30-fold relative risk of developing lung cancer compared to non-smokers. Secondhand smoke exposure is also implicated in lung cancer to a lesser degree. And earlier we talked about gas called radon, which is, according to US Environmental Protection Agency, is the second leading cause of lung cancer in this country. Asbestos exposure, also now not that common, but in the past, people used to work in an environment where they get exposed to asbestos a lot. It raises the risk of lung cancer 2 to 3 times normal. COPD is an independent risk factor for lung cancer. Exposure to certain chemicals or metals like arsenic, chromium, nickel can cause lung cancer. And nowadays, with use of CT scan too much, if you have too much radiation, you are at high risk for radiation, lung cancer, I'm sorry. Family history of lung cancer puts you at high risk for lung cancer. So these are some of the risk factors associated with lung cancer. Screening for lung cancer is now recommended for adults aged 50 to 80 who have 20-pack-year smoking history, who currently smoke, or who have quit within past 15 years. And it's a yearly screening with low-dose computed tomography, CT scan. So that's where the screening nowadays is getting more prevalent, and we see a lot of patients in the offices where people now are aware about lung cancer screening. Do you want me to go treatment options at this time?
Let me jump in here about lung cancer screening. There's a concept that you mentioned that I think is important to highlight, this idea of a pack year of tobacco use. Basically, if you multiply the amount of cigarettes you smoke per day by the number of years you smoke them, you get what's called your pack year number. The easiest example is if you smoked one pack a day for 30 years, you started when you were 20 and you quit when you were 50, you have a 30 pack year history. And once you hit age 50, you qualify for lung cancer screening. Similarly, if you smoked a half pack a day for 40 years, you'd have a 20 pack year history. And once you meet the age criteria for lung cancer screening, if you're either still smoking or you quit within the last 15 years, you get screened. And we know from various other types of cancer, like breast cancer, cervical cancer, colon cancer, that screening not only diagnoses more cancers, but diagnoses cancers at an earlier, more treatable stage. And the reason why lung cancer has become, or the reason why we developed guidelines for screening for lung cancer, is the studies that were conducted showed a 20% risk reduction of cancer-related death, just with cancer-related death. And over time, there's going to be more data published about the risk reduction of death from any cause, because the people in the screening programs, their risk of death overall reduced, I think it was somewhere between 6 and 10% from causes unrelated to lung cancer. So it's incredibly important, and it's not nearly in the public psyche the way that breast cancer screening is or colon cancer screening is. And as a result of that, the number of people that are eligible for screening, if you take that whole population, it's something abysmal, like about 5% of those people actually get screened for lung cancer. So there's a lot of people out there that qualify for lung cancer screening that aren't necessarily still smoking, that if we catch them, if we get them in a robust screening program, then we could potentially find these cancers earlier when they are treatable. There are, I'll transition into the topic of lung cancer treatment, because when we think about lung cancer, curing lung cancer, the only known cure, or the best known cure, is surgery. But in order to benefit from surgery in terms of a cure, you have to catch your lung cancer at an early enough stage. And really the only way to do that are just get lucky and happen to get a CAT scan for something else and find a nodule. And then you see either a pulmonologist or a thoracic surgeon, or you are in one of these lung cancer screening programs like the one we have here at Somerset, where you are getting your regular low dose CAT scan for screening to help catch these cancers at an earlier stage. There are certainly, surgery is not the only form of treatment. There's chemotherapy and radiation, and in the last 15 to 20 years, an increase in immunologic and biologic treatments that help control the disease. But we don't really think about them in terms of cure, really more just managing the disease and trying to keep it at bay for long enough to improve survival.
So Dr. Gerson, let me just pause you there, because I want to go back to, you talked about surgery as one of the options. Can you tell the audience about video-assisted thoracic surgery and robotic-assisted thoracic surgery, what they are, who are candidates for those types of procedures, the general stuff, the recovery time, and maybe any risks that are involved?
Sure. A lot of people who've never heard of thoracoscopic surgery probably heard of laparoscopic surgery or arthroscopic surgery. And it's the same idea that the abdominal surgeons use in laparoscopy, or the orthopedists use in arthroscopy. That is keyhole surgery. You have small holes, and you use a camera and long instruments to access the lung in a minimally invasive way. I always tell patients that you never realize how much you use all the muscles that Dr. Bavishi mentioned earlier. You never realize how much you use them to breathe until somebody puts a hole in them, because it can hurt. So these minimally invasive techniques that we've come up with, the VATS and the robotic assisted, the whole idea is to minimize the trauma to the chest wall without compromising the oncologic benefit of the surgery. And it's now very well established that if you go to a surgeon who is facile with one of these minimally invasive techniques, that it is just as safe in terms of surviving the surgery as open traditional surgery. And it is just as beneficial in terms of curing the cancer and getting all the lymph nodes and margins that you need to treat the cancer. So if you think about video-assisted thoracoscopic surgery as the direct corollary to laparoscopic surgery, robotic-assisted surgery is basically VATS surgery, except instead of the surgeon being standing by the bedside and having his hands on the instrument, there's still a camera and there's still long instruments that go through small holes, except the instruments and the camera are manipulated by robotic arms, which is then controlled by a surgeon like myself sitting at a control panel a few feet away. It has, there are pluses and minuses to robotic versus video assisted, if we could call it traditional video assisted surgery. They're both tools. They're both considered minimally invasiveness. VATS has been around longer, so we have more data to support it. But it's generally considered to be, robotic surgery is generally considered to be equal in terms of safety and efficacy in resecting the cancer. The recovery time, everybody's a little bit different. You usually wake up with a drain in your chest, and it's just a plastic tube that helps evacuate any leaking air from the surface of the lung or any fluid that that is sort of stirred up by the the inflammation of performing the surgery. The tube, the drain, is usually the thing that keeps people in the hospital, and they can stay in. Usually have to keep them in anywhere from 1 to sometimes 3, 4, or 5 days. Back to the topic we've been discussing over and over again about smoking cessation, all of these things get more. You not only have a higher risk of developing a lung cancer if you have a smoking history or you still smoke. The surgery itself can be a little bit more complicated if you have damaged lungs from a long smoking history. So you sort of you get a lot of burden from smoking, and it doesn't really help anything, and so you get no benefit from it. And then when if God forbid you end up, if you develop lung cancer and you have to go to surgery, it may complicate your recovery somewhat.
Well, thank you very much for that explanation. So what services does Steeplechase Cancer Center offer for patients with lung cancer?
We just had the lung thoracic oncology meeting this morning at a cancer center like Steeplechase. There's usually a multidisciplinary group that meets regularly that's made up of pulmonologists and medical oncologists and radiation oncologists and radiologists and pathologists and surgeons. So you get, it really is truly multidisciplinary, and you go over almost every lung cancer case that a Somerset physician has encountered, from soup to nuts, from how the patient was diagnosed and what their exposure risk is, and depending on when the meeting is, it may be before they've undergone any treatment, and then you get a chance to discuss with the other experts in the field what the best treatment plan will be for that individual patient. So if you come to the Steeplechase Cancer Center, you can know that what I'm telling you, or what your pulmonologist like Dr. Bavishi is telling you, or your oncologist is telling you, that is not that's not chosen from a fast food menu. It is truly individualized for your specific case. We're able to take things into account, like if you have an important family event coming up, or sometimes people have a particular aversion to surgery and cutting and being in the hospital. So we take all these things into account, and we usually set patients up with a nurse navigator who is like the patient's Sherpa, and shepherds you around the process, making sure you know what the steps are in your treatment plan, helping you getting them scheduled and getting through the insurance process, and is really your guide through the process from beginning to end.
Sounds good. So it sounds like they offer a multidisciplinary approach, and you really have a team of experts, if I'm hearing you correctly, that are really going to help and care for you during your treatment, as well as a navigator who's going to help you kind of navigate this whole process as well. And then, right?
That's correct. Mm-hmm.
So, and then on the diagnostic side, if I'm not mistaken, they do offer the lung cancer screening, correct?
That's true. And so we offer lung cancer screening, and it usually will be somebody like myself or Dr. Bavishi who follows the patients, because you have to have the screening yearly. But if you've already had a diagnosis of cancer and you've had surgery, for example, you still have to get periodic surveillance. And so one of the clinicians on that team will be responsible for getting you to your periodic follow-up imaging studies. And there are in the last 5 to 10 years, in particular, there's been an explosion of various types of diagnostic modalities that don't involve general anesthesia and knives and tubes. The radiologists have a lot more tools, weapons in their armamentarium for making diagnoses without having to undergo surgery, and the pulmonologists as well. And some surgeons do specialized bronchoscopic techniques where they can reach these really small lesions, nodules that are way out in the periphery of the lung that we would never have been able to access before without making an incision, and get the diagnosis, and a lot of times can steer somebody down a different step in the algorithm for the treatment that wouldn't necessarily involve surgery. So we have all of these tools at our disposal at Steeplechase and at Somerset.
So thank you for that. And one more question before I open it up to questions from our audience. So if there's one big takeaway that I've heard from both of you today, it's quit smoking if you smoke, right? Try to quit. So I think it's important that maybe can we share what services are available for people who are trying to quit smoking?
Yeah, there was actually a study in JAMA that was I just got this in the mail yesterday about, there's when I was in medical school, I learned about the organizational paradigm of the pill, the patch, and the gum. There are medications, things like Buspar and Wellbutrin, that have a long history of use and safety, which are used to help. It was basically an antidepressant that some doctor along the way realized that a lot of his patients that were on this medication who were smokers, it just so happened that a lot of them quit smoking. So they did studies, they got a new indication for the drug that it can be described purely for smoking cessation. There are newer drugs like varenicline or Chantix, which have come on the market probably in the last 15 years or so, which have a different mechanism of action, but are also efficacious in helping people quit. And then there are things that are over the counter that have been around for a long time, like the gum and the patch, and all have their role and their place. But, the point is that quitting smoking is incredibly hard. If it wasn't hard, then, nobody would smoke, or a lot fewer people would smoke. And you have to, if you're a smoker out there listening to this, you have to come to the table without fear of judgment. I mean, nobody, at least the healthcare providers, are not approaching this with any judgment, because we would be bad doctors if we use that as our motivation. And one important point that I always make is, I think as a healthcare community, we don't do a good enough job in educating the public and what the harms of smoking are. Just even in this talk, I mean, it's a lung centric talk, so we talk about things like COPD and lung cancer, and I think most lay people understand that smoking causes lung cancer for sure, but there are so many other things, so many other bad things that smoking does to our bodies that patients are so surprised to hear about when I talk to them. And even if they're not having lung surgery, smoking can impair their wound healing. If they do have an incision for something, if you're having abdominal surgery, smoking puts you at risk of complications from having your closure not heal correctly and ending up with hernias. It puts you at risk for tremendously increased risk for cardiovascular disease, and young people who would otherwise not have a reason to have heart disease die of heart attacks and strokes in their 40s, 50s, and 60s. That just shouldn't happen, and is entirely connected to smoking. So when you talk to your patients or your friends or your family, it's not just about lung cancer or being connected to an oxygen tank for the last few years of your life. There are other reasons, important reasons that shouldn't be overlooked, why smoking cessation is so important. They do have, I mean, talk to your primary care doctor, and there's other things like hypnosis, which have been helpful for some people. There's lots of tools out there. There's really no reason not to at least try some of them. I mean, they may not work, but you have to try.
And thank you. And luckily, through Robert Wood Johnson Barnabas Health, we also have the nicotine and tobacco recovery program, which I believe has a smoking cessation. So folks can also reach out to that. So lots of options to quit smoking today. So at this time, I would like to open it up to questions from our audience. If you do have a question for one of our physicians, please post it in the question and answer section of the webinar. I already see a number of questions listed here. So we'll just kick it right off. So have any studies been done on how patients who have had a lumpectomy for lung cancer do if they get COVID-19? So for instance, the cancer removed, no lymph node involvement, and vaccinated. So
to my knowledge, there haven't really been any studies, but the way I think about it is you're born with a certain amount of lung function, and there are natural things that subtract from that lung function over the years. And there are exposures like smoking and COVID, which also knock you down a peg. When most people, even a lot of smokers, have enough lung function left over to tolerate having a big portion of their lung removed for cancer and still go on with the rest of their life relatively without ill effects. So COVID, if you've had lung cancer surgery and you had a lobe removed, for example, and you contract COVID-19 and your lungs are affected from that as well. I mean, it's a simple math equation. You started at X percent function, you had some removed, which knocks you down to Y, and then you get COVID, which knocks you down even further. But we still don't know exactly what happens. The natural history of people that have severe, for example, pulmonary fibrosis or ARDS from COVID-19, in the long term, we're talking years down the road, but it's pretty safe to assume that if you're dealing with if you're not dealing with a full deck because you've either smoked or you've had part of your lung removed for cancer, and then you have your function reduced even more by COVID, that you could run into some problems. But what we don't know is what happens if you regain that function over a longer period of time. I think that they're doing lots of follow-up studies with pulmonary function tests in people that have had COVID. So I'm just extrapolating here, but some people do recover their lung function after they get over the respiratory illness, but it takes months.
Okay, so I'm going to keep on the COVID line because we have a number of questions regarding COVID and lungs. So how do we exercise in this COVID time? So who would like to field that one? Dr. Bavishi?
Yeah, good question. I mean, as I mentioned earlier, exercise is an important part of your lung health, and 30 is recommended. Now, it's a COVID time, so I understand people don't want to, go to the park where, they're not comfortable with other people exercising next to them. But keep your distance, and wear the mask. Two important things to prevent you getting COVID. So cleaning your hands with soap and water, using alcohol-based rubs if soap and water is not available, doing exercise in an environment where you are not next to a lot of people. or doing it at home. You can go for biking, you can go for running, jogging. So these are some of the things that you can do, and keep in mind about the precautions that you need to take to protect yourself from COVID-19.
Get vaccinated.
Yes.
Yeah, right, get vaccinated. Well, and then this next question, again, along the COVID line is, how many people with asthma are affected by COVID and how can they protect themselves more than average? So, and when I guess this person is saying more than average, more than the 4 W's, as we say here at the hospital: wearing your mask, washing your distance, let's see, wearing your mask,
Washing your hands.
Washing your hands, right, and when sick, stay home. So I guess more than those 4 things. Who would like to kick that one off? Dr. Bavishi?
I'm sorry, can you repeat the question?
Okay, so how many people with asthma are
Yeah.
affected by COVID? And then
Okay.
how can they protect themselves more than average? So I'm saying more than average being the 4 W's of wearing your mask, watching your distance, washing your hands regularly, and when sick, stay home.
I am not aware about the data of how many people of asthma has gotten COVID. As you know, the COVID pandemic is still ongoing, and there are a lot of studies being done who is at risk and which patients are more likely to get it compared to others. Like we know, some immunocompromising condition puts you at higher risk for having COVID. Similarly, chronic medical conditions can put you at higher risk for having COVID. But I am not aware about what exactly is the percentage of the people of asthma getting COVID. And in terms of protecting yourself from COVID, more than average, I think the average measures would suffice, right? It's a common sense measures that, are recommended, as you mentioned, with the 4 W's. But more than that, for people who have underlying conditions, that might be specific to their particular lung condition, speak to your doctors about, getting the best advice. It may be individual or specific to your particular condition and the stage of your lung health at that time.
Okay. Another question: can the portable O2 sensors adequate for monitoring O2, the oxygen levels in the lungs if we have COVID, or just checking if they are type A for COVID? I guess it's saying, are the portable oxygen sensors adequate for monitoring oxygen levels in the lungs if somebody has COVID? Or do they just check for type A? We can take the first half.
I'm not sure. Yeah, I'm not sure what type A means, but generally the pulse oximeter available in the pharmacies like Walgreens or CVS that people can buy, and some of the patients with chronic medical condition like COPD who are on oxygen uses at home can provide fair, accurate estimation of oxygen level in your body. So they are important for monitoring. Now, I wouldn't suggest that if your oxygen level is low because of COVID condition, you monitor your oxygen level at home and don't consult a healthcare provider. Please do talk to your doctor, get medical attention, and as you may qualify for some of the treatment if your oxygen level is low. But in terms of monitoring and the effectiveness, I think it's fairly accurate in providing you estimate of oxygen in your body.
Okay, great, thank you. So these next 2 questions are regarding the lung cancer screen, a comment and 2 questions. So unfortunately, most primary physicians do not even mention the screening, the lung cancer screen, not even at annual checkups. So how can we get more awareness to the screening, and is it covered by insurance? Dr. Gerson, would you like to field those?
I'll answer the second question first because that's easy. The answer is most commercial insurances do cover if you meet the criteria. And, the United States Task Force, Preventative Health Task Force, just updated the recommendations last March, and the various major health insurance providers are also updating their coverage guidelines. Medicare, if I'm not mistaken, has not adopted them yet, but the point is, this gets to this. The first question is, all we can do is increase awareness. I am personally on a mission when I speak to primary care doctors to ask, to make sure they know that they should be asking about lung cancer screening at the same time as they're encouraging their patients to get mammograms and colonoscopies. And hopefully with more sophisticated electronic medical records, we can have alerts pop up similar to getting an alert about a text message on your phone or your watch that says the doctor, primary care provider, the patient you're seeing is between the age of 50 or 55 and 75 or 80, and they smoked long enough and they didn't quit that long ago. You should send them for lung cancer screening. I mentioned this earlier, that the number of people that qualify, or the percentage of people that qualify for screening that are actually getting screened, is abysmally low. And I know that we are missing a lot of people out there that we could probably cure. So, it's a relatively new idea, this concept of lung cancer screening. And all we can do is just keep trying to increase the awareness.
Okay.
It's kind of an unsatisfying answer, but it's what we have.
Oh, thank you. That's right. That's part of the reason we do webinars like this, is to create the awareness and educate people that service is available. So thank you. So just to go back to that original question about portable oxygen sensors, there was clarification on what that type A means, and that this individual was referring to somebody who was asymptomatic, no symptoms for COVID, but had COVID. So if I were to, re-ask that question, was can the portable oxygen sensors, were they adequate for monitoring the oxygen levels, or just for checking for somebody who's asymptomatic with COVID? So I'm not sure.
Well, I think the point is that if you are asymptomatic, but you're checking your oxygen levels with one of those monitors, and your oxygen levels are low, well, then you're not asymptomatic anymore. But if you're asymptomatic and you know that you're positive and your oxygen levels are normal, that doesn't mean that you're not contagious. That doesn't mean you're out of the woods. That doesn't mean that you're not going to have some of these long COVID symptoms, which is why COVID-19 is, a very sinister, insidious problem.
Thank you. Thank you for that explanation. Now I have last question, kind of a little bit of a scenario. My 89-year-old mother has slight emphysema and struggles with wearing a face mask to breathe effectively. Her exercises include house cleaning and brief walks. She never smoked and worked around others who did. What can she do organically at her age to offset those bouts of breathing difficulties besides using an inhaler once in a great while? And is COPD the same as emphysema?
Emphysema is not same as COPD. Emphysema is the damage to your lungs that we see on radiological testing. And along with the symptoms of COPD, when the patient goes to the doctor's office, they do certain testing called pulmonary function tests, which then diagnose patient with COPD. If you have a patient with a COPD who is on an inhaler, to make them feel better, there are certain other ways. As I mentioned about importance of exercise before, the breathing exercise in particular is an important tool to keep your lungs healthy, even when you have advanced diseases like COPD. Pulmonary rehabilitation is also recommended and to improve your overall health and also to improve your lung health, which allows you to continue to do your routine day-to-day activities and prevent routine vaccinations with your flu and pneumonia shots if you qualify. Also helps prevent respiratory infection and keep your lungs in a better condition and keeps you healthy. Your individual situation should be discussed with your primary doctor or with your pulmonary doctor to get recommendations that specifically fit your needs and your condition, I would say.
The point about exercise is, I mean, it's something important to remember is you don't need sophisticated equipment or a gym membership, and you don't have to do it for hours and hours every day. Simple walking for walking's sake, just carving out some time in your day that just doing some extra walking that's beyond what you do in your normal day-to-day lives can help. And you know, there are muscles involved, as Dr. Bavishi outlined so clearly earlier. And when you do exercises, when you have an exercise routine, you are working out those muscles, which will then in turn pay dividends for your lung function. So, you know, you don't, like I said, you don't need to have a gym membership or sophisticated equipment, a stationary bicycle for when it gets cold outside, and, you know, walking around your neighborhood while the weather is still warm enough. You know, it's really all you need to do for, you know, if you can do it 30 minutes or more, that helps.
Great.
And if you're limited by your COPD, then, you know, the point of something like pulmonary rehab is you try to get a little bit further each time, and you can increase your exercise tolerance that way.
Okay. One last question, because I know we're past our time, but what causes pulmonary hypertension and what is the treatments for it? Good question.
Yeah, it's a big topic, pulmonary hypertension, and there are various kinds of pulmonary hypertension. We call it group 1, 2, 3, 4, 5. And various diseases cause pulmonary hypertension, like COPD and many other many other cardiac conditions, like having a lot of clots in the blood vessels of your lungs, and like many connective tissue diseases. So there are various reasons people can have pulmonary hypertension, and sometimes doctors don't find any reason. We call it idiopathic pulmonary hypertension. So I would limit it there. It's a big topic, as I mentioned.
The treatments are specific to the treatments are specific to each cause.
Yes, absolutely.
All right. Very good. Well, thank you both so much for this very comprehensive presentation. So this will actually conclude today's webinar. We'd like to thank all of you for joining us. Please remember that our opinions expressed here today by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call our physician referral line at 1-888-724-7123. For more information about lung health, please visit our website at www.rwjbh.org/Somerset. On behalf of Robert Wood Johnson University Hospital, Somerset, thank you all for participating in this morning's webinar. Have a great day, everyone.